Actually, I think I could, there's a little, where to go? Thought there was something I could click on. Guess not. Okay, we could begin. Next slide. So in our little bit of time here for our didactic portion, we basically wanted, there was a request to go over pain management guidelines as far as, of course, a brief mention on the national level, but then really looking at what we've done and what we're doing here in West Virginia. As far as objectives go, it's really to review those and really to take into consideration that guidelines are there for guidance. It doesn't always work out for every single patient because you got to take into account all the patient-specific factors, of course. But general guidance as far as what I would call, first off, the what do I do with my hands and my mouth? We'll get there. And then also the treatment selection when it comes, especially to the pharmacologic, even non-pharm side. So next slide. Not to beat the drum, but I'm sure everyone's already familiar with the 2016 CDC chronic pain opioid guidelines. That's the most concise version I could find right there, but there's a lot of words on there. Building upon those, next slide. In that same year, we basically, and the year before, had gotten together a quote-unquote expert panel within our state to be truly interprofessional and even geographically diverse throughout the state, as far as MDs, DOs, pharmacists, nurse, psychology, dentistry, even on the insurance side, if you notice a few there, having them involved along the way, and the Board of Pharmacy along as well for the PDMP. Trying to get as many, nothing's perfect, but as many people at the table from different silos that we end up in to really have a concerted effort across the board. So next slide. Readily available online. It's just sempguidelines.org. That's short for Safe and Effective Management of Pain Guidelines. We did not mention the WV or the West Virginia because the hope was to make this something that could be accessed and utilized even across the country. But here at home in our wild and wonderful state, the guidelines have been endorsed by basically all of the major state healthcare organizations, as you see here listed, of course. As I always like to mention, even that picture in the background was from within healthcare. One of our pharmacists in our school pharmacy took that picture. So, next slide. This is one of those slides that we usually reference as what not to do, because there's TMI, way too much info on one slide, but just really big picture here. There's two main parts to this particular set of pain management guidelines for our state. Towards the right here, we'll go over briefly the risk reduction strategy, if you will. And that's what me just being me, say that's what I do with my hands and my mouth. And then as far as the stoplight approach on the left here, that's the different treatment algorithms. And I will say that our state went a little bit further than many other states and organizations to say that, yes, you need evidence-based practice like no other, but at some point there's a lot of people dying from drug overdoses every 8 minutes in our country. And that is predominantly now on the illicit substance side, but there is still a component, of course, from the healthcare side, if you will, intertangled in there, or at least the illicit side. So first, we'll just want to go over, next slide, the risk reduction strategy here. And very brief and succinct title there, but probably eminent is the patient risk reduction, but this is also to reduce risk for providers and healthcare professionals as well. Back in 2015, leading into 16, in our state, we caught national headlines for the liability risks and whatnot. So current laws that are out there basically say if you're setting and following a generally acceptable, I'm forgetting the wording, on the legalese side of things, set of guidelines, then you're good. So that's where these come into play for our state. So going over the risk reduction strategy here first, next slide. Just going to pick a couple of these things along the way. But the first thing, and many, if not all, are doing this, but take a time, work back 10, 20 years, and it wasn't always the case, but having the contract, the agreement, whatever one wants to call it really, but the patient-provider agreement, and then a couple of suggestions as far as what to include in that. If asking me personally, I say it's all about the conversation. We certainly do have to document everything, and that's the point of the paper or electronic version, but it's all about the conversation. So we'll touch on some of these points here briefly of what to include in the contract to begin with. Even on the trailing part there, it's the contingency plan. Going over in the beginning, hey, if things go awry, here's what we're going to do, really helps out when things go awry. When and if, of course. Next slide. So a couple of these individual things, starting with the very basics, I'm sure you'd all agree, just goal setting, the proverbial SMART goals. And here we'd be talking about, we'll jump right to the yellow, what's probably most important is the improved function and reduce pain. Here within, and we're pretty fluent with using the DVPRS, which really does focus as a pain scale on not just the pain number, but of course those other things like sleep, mood, and whatnot. Function, basically. Jumping back up to the top, though, as far as we've all heard about the pain fifth vital sign coming from the 90s, or was it Big Pharma? Was it professional organizations? The debate goes on. I feel like I'm the one person in America that actually embraces that, but with good intent. And where I'm going with that statement is that if we do view pain as the proverbial fifth vital sign, think of the other vital signs. They, by definition, keep us alive. So back in the we put our hand in fire, pain tells us, get that thing out of there. It's also thermal, but we'll call it pain. So that does help to keep the vital part. That being said, do we ever completely suppress respiratory rate? Silliest thing you're going to hear today. Same thing goes for heart rate. So if you're thinking that pain scale, of course, I'm going directly to that. Somebody's a 10, our goal is not a 0, just like it would be for respiratory rate and heart rate. So that's perhaps a little bit of a different way of looking at it and embracing that whole vital sign thing, but then taking it right to the treatment side of what we're looking to do. On top of that, my next little bullet point here is analgesic. It's actually, that is derived from Greek to mean without pain. So I'm a pharmacist. Think about me running a pharmacy, and you're going to go down my aisle 5, 6, 7, whatever it is, and it's going to be labeled analgesics. I'm not proposing that the lay public knows that analgesic means without pain, but technically what we're putting on there as a goal is without pain in every aisle in every pharmacy. So that's just something to contemplate in the back of our heads. The goal really is all about function and mood and whatnot, and pain, of course, too. So now next slide. I alluded to the DVPRS. Here it is, of course. We already used this in our ECHO program here. So I'm not going to spend much time on that here now. Next slide. Here's a topic that people would go on for 3 hours, and I'm going to do my best not to do that because, boy, we don't have 3 hours. Proper medication storage. Basically never use a medicine cabinet. We kind of destroy the name of that, too. Due to humidity and safety and all that stuff, lock it up. The one thing I would say, though, is to really help our patients is to say lock everything up. Yes, the lisinopril, the metoprolol, and the oxycodone. That way we're not teaching people that, oh, this opioid is valuable, but my lisinopril is not. If my 2-year-old takes 10 of either, we're going to the ER. So lock it all up. Now to the fun side, as far as disposal, this one I believe just about every other healthcare professional struggle with. Typically we think about it on the patient side, but if we are even giving an opioid or a controlled substance, what are the odds of each one of us, please don't answer or raise hands, but just ask yourself that question. Who would actually throw it away? And if 100% of people in a room as professionals can't answer yes, then whew, that's going to be a tough goal to hit with our patients. I've had a lot of talks with other professionals along the way, and they're not getting rid of it either. And I start thinking, then how do we expect others to do it? But at least lock it up. As far as when throwing it away, sorry, the FDA and the EPA get along for the most part for guidance, but then the idea, the last one there, number 4, the flushing the list of, I think it's down to 20 or 30 now, of the controlled substances, primarily opioid medications. That's what the FDA says. However, the EPA says, what about the fishes? And humans ultimately too, of course. That's a battle that keeps on going. It would be wonderful to be clarified in unity on that, but we're not there yet. On the healthcare side with the FDA, they do say for those medicines that we flush them. Next slide. On the psych side of things, more psychology than psychiatry, but this PHQ-2, I'm sure many are familiar with it. 2 quick questions or scenarios to go over with someone. I had this done on myself not that long ago, about 2-3 months ago. I had my annual physical and lab and whatnot. And when they went down the myriad of questions, 2 of them were these questions. And I immediately looked at them and said, "You just PHQ2'd me." And then they gave me that look of, "Oh my gosh, she's on to us." Um, but the point is, it's 2 questions. And even if you have 10, 15 minutes, pretty easy to do. That would lead, if someone screened higher for that, equal to or above 3, then you'd be doing 9 questions basically. And then we're getting to the specialist side. The big point here, though, is that these things are relatively easy to work into given practice. Next slide, please. On top of that, as if we didn't have enough to do in our 15 to 30 minutes, there's opioid risk screenings. Not going to go into the specifics for each of these, and there are others that are not on this list. But the big idea here, I boil it down to 2 questions. First off, has the person had an opioid medication before? Yes or no? So naive or experienced? Once you got that answer, then you want to know if you're going to be, or your staff, your team are going to be administering the screening, or if it's something you're going to hand to them with the other papers before an appointment. Those are the 2 main questions that would guide somebody as to which one to use. So for instance, if someone has not utilized an opioid before, we're talking, say, the high schooler with a football injury, perhaps, and you want to ask a couple questions, then it's provider reported. You might be looking at the opioid risk tool or the DEA or the DIRE. Just that process is what I wanted to mention today, though. Next slide. Still going through the whole risk reduction strategy here overall. There's, of course, medication interactions we could talk about forever, but I only wanted to point out that there's multiple different types, of course, not just your typical SIP enzymes and whatnot and sedatives, but also things like the diversity of pharmacogenetics, gender, age. We had that in our case today where I believe it was a elderly female. Say she was on something like Zolpidem, we'd have to factor that in, or even citalopram as opposed to the sertraline she was on. Next slide. Just obviously highlighting the, like we had in our case here today, opioids, benzos, relaxants, quote unquote, and hypnotics, the deadly duos, if you will, unholy trinity, and so on. Next slide. And then as something we didn't touch on today, and I think I purposely reserved it, something just to touch on with even the patient in the case today, being that she had some respiratory issues and was also on an opioid and a benzo. Not necessarily always providing a naloxone product, but at least bringing it up in conversation. So in case I missed that, I apologize, but that's something that could be brought up. If I had to tell somebody one thing about the different naloxone products, I would point out, beyond obviously they would know the differences in price, as far as the intranasal options, the manual kits that we put together, the second one here, that's basically a spray in each nostril, so 2 nostrils. And whereas the readily put together Narcan nasal spray, brand name if you will, is 1 spray in 1 nostril. That's, I think, something that really stands out, and I hope I put it in red here to emphasize that. Next slide. As far as urine drug screening and testing, of course, we want to be doing this. I'm sitting in our pain center right now, and it is always done. And it could lead to some interesting conversations, if you will, or it could be a mundane thing if it's a different scenario. But the big picture here, this could be a talk in itself, of course. The cup, that's a conversation starter. That fancy HPLC, I believe that one is, or liquid chrome, I believe, that's the conversation leader. That's a different conversation when you know that it's more expensive testing as compared to the screening. That's a different conversation because you know the answer in the end. Whereas just like with a pregnancy test, there could be false positives or negatives, and it certainly doesn't tell you if you're having a boy or a girl. There's some issues with the cups, but they're cheaper and they're easier to use, but just different talking points there. So next slide, please. As far as PDMPs, generally speaking, we can almost say that every state in our country has a PDMP program now. The one little asterisk goes to Missouri. We just had elections 2 weeks ago. The one that was elected as a senator has already pledged that they will definitely have one in their state. There is already on the county level in some of the counties in Missouri PDMP that is active. So that's imminently going to happen, and then we can say that every state has it. The data is shared across states. It's shared based on what software a given state uses. You would think that it would be, well, who's ever local to you? But here in West Virginia, we also share with Nevada. And it's not just because Las Vegas is really cool. They just happen, that state uses the same software as us. The day may come where everybody uses this, though. Next slide, please. As far as DEA red flags, the other things to watch for here in this reduction of risk, I provided a link to a video at the bottom if you'd like. What I normally like to say, though, is there, as healthcare professionals, there's this fifth, sixth sense in us that we tend to just know these things. You know, when something's out of place. If you're coming from far distances, only wanting to pay cash, looking for the same combinations of medicines all the time, whether it's the prescriber or the dispenser, pharmacist, or whatnot. We tend to know what to look for. Next slide. The part that really is tough is, well, once you find it, now what do you do? The CEO of our American Pharmacists Association once said it to me the best as portrayed in this picture. Once the dog catches the car, now what? And that's a whole issue in itself, of course, of how to deal with that. Hopefully, though, as we already covered, including some of those within a patient provider agreement or contract in the beginning will make that road a little bit easier. Next slide, please. That pretty much wraps up in the quickest nutshell I could possibly do for the risk reduction strategy portion of the guidelines. Next slide. Next up and next slide will be the idea of these treatment algorithms. There's nothing perfect in the world, but the idea here was to take that next step because we even as a country, let alone state, need to have something as a plan. This video that I'm showing here is actually taken off the internet, so couldn't show the video, but it is a pretty dicey one. It shows a teenage female going to the ER for, I believe, a tennis injury or something, and her parents are there, and the doc prescribed, excuse me, ibuprofen. And the parents are like, come on, man, that's not enough. What are you talking about? So then he writes down on the same piece of paper, heroin. And they say, what are you, out of your mind? And then they go back to the ibuprofen. Now, that typically gets people going one direction or the other. But the overall idea there, it doesn't settle well with me either. But the overall idea there is, heroin is diacetylmorphine. So on a structural level, chemical level, there's a point to it. But let's be real, it's also heroin and not dosed in our country as compared to others. So next slide. That was basically my segue into having a plan of attack. So there's a couple things in between ibuprofen and any opioid medication. In the sake of time here today, I'll just refer to everyone could certainly pull these off of the internet on the webpage. We have the SEMPguidelines.org. But the overall idea here is to have a strategy to go with the less riskier things first. Not really reinventing the wheel, of course, but then always reminding to go backwards and use combinations, of course. And the first thing that's mentioned is the non-pharmacological treatments. There's at least 24, generally speaking. One strategy that I use for those is to categorize them as active or passive. Active meaning that it's a patient that wants to be a part of their treatment plan. Passive being, hey, take care of me, doc. That at least provides a little bit of guidance where to go. And jumping in between those. So if it's a, hey, take care of me situation, massage might be an option. If it's a, I want to do it, yoga might be an option. Just things to think about there. Generally speaking, this is also by controlled substance class. So that way, if there's changes to laws, the guidelines would still be. I believe we could jump ahead 2 or 3 slides actually to the last part. Those are there basically for your reference. That's the overall our state pain management guidelines in a nutshell. Just remembering the 2 big parts, and finally an entity jumped ahead to actually have some treatment algorithms as an update to those 1980 whatever it was WHO ladder with like 4 options. So I know we've used up everyone's time, but if there's any questions, feel free. We could certainly shoot them out afterwards as well too.
Excellent. Thank you so much.
You're welcome. And I apologize to everyone again for my voice. It's been a rough week. Ironically, I'll give you a side story. I went to a provider earlier this week, and I was a drug seeker. That meaning I was past the point of antibiotic stewardship, and I was seeking to get an antibiotic. So I was a drug seeker, and I left with an opioid.
Oh.
Can you believe that in 2018? It was codeine, folks. Don't go crazy. Only overnight, though. That's why I'm awake right now. So.
Are there any questions? We only have a couple minutes left. No? Okay. So our next session is on November 29th. I encourage everybody to turn in some cases. And if there are any topics you want to hear about, of course, let me know. We'll get those handled. All right. And everybody have a great day, even though it's cold and yucky. And,
Yeah, happy Thanksgiving.
And yeah, happy Thanksgiving.